Thank you for asking me to talk about another dreadful disease but highly curable disease called as testicular cancer. Every man has two testicles. They are in the scrotal position called as a scrotal bag, and that's a normal situation. Now when the tumor develops in the testes, one of these testes, then the patient would notice the pain, discomfort and increase in the size of the testicle. In some situations, when the testis is not in the scrotal bag, but unfortunately by birth, if it is in the abdomen, then these patients have a high chance of developing cancer in their testes, and therefore, as the children are born, we try and make sure both the testes are in the scrotal bag, and if not, they should be investigated for undesended testes, and that rectification, that performing an orchidopexy, bringing the testis into the scrotum, has to be done before the age of 18 months. Now, once a diagnosis of testicular cancer is suspected, when the patients present with the swelling in the testes, I think it's important that you have a stepwise algorithm in diagnosing and treating these patients. Any mess up in this stage-wise algorithm can be really counterproductive, and you can give inadequate treatment to these patients. So important, when you have swelling in the testes, when you are suspected to have a testicular cancer, you see a team of a urological oncologist, medical oncologist and a radiation oncologist to tailor your treatment appropriately, because if you don't do that, you are going to play with your life and playing with the fire. Now, testicular cancer can present broadly into three stages. If the tumor in the testis is just limited to the testis and it has not gone beyond the confines of the testis, gone not anywhere else, is called as a stage 1 disease. If the tumor from the testes through the lymphatics or through the blood system, if it has gone into the lymph nodes or anywhere else, that's called as a metastatic disease. In stage 2 disease, you have this testicular tumor implantation into the lymph nodes below the diaphragm. If it is less than 2 cm, we call it as a stage 2A. If it is in the lymph nodes and the lymph node mass is between 2 to 5 cm, is called as stage 2B. And if it is a bigger lymph node mass, which is many times the situation, is called as stage 2C. In stage 3, these tumorous cells from the testes would have gone to the lymph nodes above the diaphragm, and in stage 4, you would have lung metastasis or a visceral metastasis. Now, when you have a suspicion of a testicular cancer, apart from clinical examination, what we do is a test important called as tumor markers. So what are the tumor markers in testicular cancer? We mainly rely on a test called as AFP, that is alpha fetoproteins, a second test called as beta HCG, and a third test called as an LDH, which tell you the extent of the disease. Now, third important thing what you need to do is to do a complete CT scan of the chest as well as the abdomen to know the extent of the tumor. So in a stepwise fashion, you have a case with suspicion of a testicular malignancy. The second step is you do a testicular markers. The third step you do is to find out the stage of the disease in the terms of CT scan of the chest and the abdomen. Now, what we need to do once you have suspicion of a diagnosis is to establish a tissue diagnosis. And how do we do that? By removing the testes by an operation called as a high orchidectomy. The side on which the testis has tumor, we make a small incision into the groin, remove the testis entirely along with the spermatic cord, and get a histology on this tumor. Now, there are two types of tumors in testes. One is called as a seminoma, and the other called is a non-seminoma germ cell tumor. Very easy and very simple. Your pathologist would tell you, if it is non-seminoma, what are the elements in this non-seminoma? Maybe it's a choriocarcinoma, teratoma, embryonal carcinoma, and we need to know a percentage of these tumors in the non-seminomatous testicular tumor. So step 4 is to get a tissue diagnosis after doing an orchidectomy. Once we know that, we wait for about couple of week times, then we repeat the tumor markers and then subsequently take a call. If the patient's tumor markers return to normal. The primary tumor has been removed. If the CT scan chest and abdomen is normal, this qualifies as a stage 1 seminoma or a non-seminomatous germ cell tumor. If it is a stage 1 seminoma, we can offer them active surveillance or a prophylactic radiation to the retroperitonum or a single agent carboplatin therapy. If it is stage 1 non-seminomatous germ cell tumor, we can offer them active surveillance or 2 cycles of chemotherapy or single agent carboplatin therapy. Some people would actually give them a chance by staging the disease by doing a prophylactic or staging primary RPLND, meaning removing the lymph nodes in the retroperitonum to have appropriate staging. If you have a stage 2 disease in seminoma, stage 2A, these patients can be treated with radiation in the retroperitonum. All stage 2A non-seminomatous tumors, stage 2B, C, seminoma and non-seminomatous germ cell tumors are treated with a chemotherapy called as the BEP chemotherapy. If it is stage 3 and 4, these patients get BEP chemotherapy irrespective of histology. So if it is seminoma, a stage 1, you can do ocheectomy and treat it either with prophylactic radiation or active surveillance or cisplatinum or carboplatin therapy. And if it is stage 1 non-seminomatous germ cell tumor, either you do primary RPLND or active surveillance or 2 cycles of BEP. Rest of them get BEP chemotherapy. Now once the chemotherapy is given, we evaluate these patients for response of chemotherapy. You will be surprised, patients who have large big lymph nodes in the retroperitonum or in the mediastinum or the lungs, everything disappears and melts after chemotherapy. So what do we do with those? Those masses which are significant on a CT scan, and if the markers are normal, we do an operation called as post-chemotherapy RPLND, meaning that all the lymph nodes which are regressed but still present of significant size, we remove them. Again, this operation is not very easy operation. It has to be done by a urological oncologist who is expert in this field and should be doing at least 10 to 15 operations every year because they're highly technically demanding operations. What do we do these operations? We open the abdomen and we skeletonize the big blood vessels called as aorta and vena cava and remove all those lymph nodes for the possibility of not developing tumor in future. If by chance, if you find tumor in those, then subsequently these patients get further chemotherapy. Now remember, if you skip any of these steps, then you can imagine what can happen to the patient. So therefore, don't get scared about a testicular cancer. See an appropriate and a proper, trained and experienced urological oncologist and get your treatment in an appropriate fashion. Now all these people are young. If they're yet to finish their fertility, then we do sperm preservation before this operation. We counsel them about the fertility after operation. Sometimes we put a prosthesis to have equality into the scrotum because one testis be removed can be very significant harm to his body image. So I'm sure you would have understood that this is a highly curable disease, but still has to be treated in an appropriate fashion. I must say at the end of this that had it not been the discovery of cisplatin by a famous doctor called as Einhorn from Indiana University and John Donohue, a surgeon who did RPLND and popularized, the cure rate from testicular cancer from 9% to 90% would not have been possible. What a great change in the field of oncology, and I call this as a great success story in the field of oncology.